So most of us in palliative care, we get patient referrals specifically for oxygen or with oxygen or home ventilation. And many a times we may not be very, we don't know how to manage this, what all instructions to be given to the caregivers at home, how frequent we should have a check on it. So we thought very important and relevant for all of us. Today we have Dr. Dipti as our faculty. I don't know Rajam is here or not, but thanks Rajam for bringing in such wonderful faculty for this program. Dr. Dipti is the professor and head at ESI Hospital, Delhi. She has done her MD Pulmonary Medicine from BL Nair Hospital, Mumbai. And when we were going through her CV, we could see at least hundreds of PubMed indexed publications that she has. Thank you so much, ma'am, for agreeing to be part of this program. Uh, we have a bunch of palliative care physicians where we deal with patients mostly in the community and at home, where we don't have much of help from consultants. Most of them are practicing as standalone palliative care physicians in the community. So this session is going to be very, very useful for all of us when we get such referrals. Rajam, I made a very brief introduction about Dr. Dipti. If you want to add something, please.
Ma'am, you're muted. Dr. Rajam, you're muted. Dr. Rajam, we can't hear you if you're speaking.
I think she's trying to, unmute.
Sorry about all this. I don't know, my phone is playing up and so is my computer. But I missed the first bit of the introduction. All I want to say is Dipti's been a dear friend since 1992, and she was 1990. I joined for MD 92 and Dipti followed me, but she's way ahead than me in pulmonary medicine. She actually is running a DM program in Delhi, and she's really gone places, and it's lovely and proud to see a friend and colleague do so well in life. I'm sure you're in for a treat. And Dipti, I'll warn you that this bunch is very interested in knowing about respiratory medicine, and we've always had an interactive session, and I'm sure they're going to have a good time. So over to you, Dipti, without wasting much time.
Okay, so I don't think I can see the participants. These are all the people who are kind of helping you out in,
They're all trained palliative care physicians in their own.
I can see them, or they are not there on the.
Switch to gallery. Switch to gallery, and you'll see everybody.
Okay. So good to have you.
They are very senior physicians, and they really do a lot of great work on the field and in the community.
Yeah. So it will be nice if they can, keep their cameras also on, so I can have some little bit of interaction, whatever way I can. So as far as oxygen therapy, I hope you can hear me well.
Yes,
I can. I'm heard well?
Yes, ma'am. Yes.
Okay. So as far as oxygen therapy and NIV and home ventilation is concerned, so behind is my hospital. So trust me, when I joined this hospital, it was not like this. This looks like a very swanky place and very nice place. It was in a pathetic state. I can tell you, if your patients of COPD or respiratory failure are there, if they are started on oxygen therapy and NIV, they can look like this. They can actually live a good life. So you must not discount them once they are on oxygen therapy and NIV, and they should be, made to use their equipments well, and they can really do well and can have a very satisfactory palliative care. Now coming to LTOT first, because I'll take LTOT first and then NIV. As far as LTOT is concerned, it's been said that tobacco cessation and oxygen therapy are the only interventions proven to prolong survival of COPD patients. Now I can say that it is not end of life care. Actually, it is beginning of life care for a chronic. Somebody has two devices on. So yeah. So as far as oxygen is concerned, it definitely improves the survival and actually improves the quality of life too. When do we give oxygen therapy? So when you're talking about when do we give oxygen therapy in terms of their ABG or in terms of their hypoxia, there were two trials conducted 35 years ago, and these were landmark trials. MRC trial and NORD trial are these trials. Both these trials actually proved or paved the way for LTOT. And trust me, these are the only trial, and the evidence so far also holds back to these two trials as far as the oxygen therapy is concerned in terms of when to give. So when to give is when the oxygen levels is less than 55 millimeters of mercury or less than 59 millimeters of mercury with edema, hematocrit more than 55 or cor pulmonale. It should be given for 15 to 18 hours per day. I always tell my patients 18 hours per day. As far as the patients are concerned, that the trials are concerned, they say that 15 hours per day is good enough. But I say 18 hours, that way at least they'll take at least for 15 hours. So I always say 18 hours per day for these patients, though the evidence proves 15 hours is good enough. Now, this trial was done for COPD patients. However, it is extended, the indication is extended for all those patients who are having chronic respiratory failure, which includes your interstitial lung disease, post-infectious obliterative bronchiolitis, post-cavitatory fibrocavitatory lung disease, any terminal lung diseases, one can prescribe long-term oxygen therapy. I'm repeating this for how long it should be given, 15 to 18 hours per day. Trial said 15. I always say 18 hours per day so that at least they take it for 15 hours. This is very, very, very important part. Most physicians forget to tell patients, either feel they have to take 24 hours or they feel that they have to check the saturation. And then if it is less than 90, then you do it. That's not the case. You can take it even if one doesn't need to keep checking the saturation. They are not supposed to be provided with a pulse oximeter. These pandemic has made us very much, used to pulse oximetry. But no, once they have that indication, which I just described, don't need to, keep checking the oxygen saturation again and again. They have to just be instructed 15 to 18 hours per day. That's it. Can it be given to the patients who do not fulfill the above criteria? So far, we have no evidence regarding the same. So the patients who have PO2 less than 55 or between 55 to 59 with cor pulmonale only need to be given. Rest, the indication is not there. How do we give? We give it with the help of oxygen concentrator and oxygen concentrator only, not with the help of cylinder. Trust me, this cylinder costs about 50,000. Post-pandemic, the second-hand ones are available even in 20 to 30,000. And it is worth investing that 30,000 for them because the cylinder, over a period of time, they keep getting discharged. They keep, whatever happens, you have to please explain to them that concentrator is worth investing into because it improves not only the quantity but quality of life. So 50,000 is not a big investment for them. For normal people these days, it's like pretty easy. Now, cylinder, absolute no. Any other devices are there? Yes, there are many other devices, like this is called a liquid oxygen, system, where the oxygen is compressed into the liquid system, and this liquid system basically helps them compress the oxygen, and the weight becomes less. So the weight of the machine becomes, or the device becomes less. Because of that, they can carry it around too and use it whenever they are they've gone to, let's say, workplace, or they're running, or they are kind of involved into a long physical exercise. Then also they can use it. So liquid oxygen is useful for that. This is a mobile. These are the concentrators. These are concentrator. One can refill a gas or oxygen into a small cylinder, which helps them do a day-to-day exercises or day-to-day, going to the washroom, etc. Because going to the washroom sometimes makes them really uncomfortable, makes them really breathless. because of that, what happens is that they start having constipation and stuff like that, and they are unable to do their daily activities easily. So these are the concentrator with which you can fill in the oxygen in these small devices out here, and they can use that when they are doing small odd jobs which take around 15-20 minutes to half an hour. So these oxygen are available with the level bliss or respironic devices. These are small mini oxygen concentrator. They are very small ones and they can easily carry it around. I'll tell you why exactly I'm describing these devices to you. Per se, as far as oxygen ambulatory therapy is concerned, there is no role. There have been 4 trials, and all 4 trials say that there is no role of ambulatory oxygen per se. However, ambulatory oxygen is sometimes useful for them when they have to go for long walks, or they have to do a physical rehabilitation, or they have to do some exercises which are useful otherwise for them for their well-being. So per se, a normal person who is not doing much of exercises, ambulatory oxygen really has no such advantage. So provision of ambulatory oxygen therapy is an exception. I tell you, I'll share a story of 2-3 of my patients. One of the patients actually was a vada pav seller. He used to stand on a railway platform. I'm sure Rajam would also remember this patient. So he would go to his, station, railway station, Mumbai railway station, sell his vada pav for 6 to 8 hours, not use oxygen at that point of time, come home and use it for 15 to 18 hours per day. Another patient was a manual laborer of mine. This patient also used to not carry oxygen. He used to come home and take it for 15 hours, because 15 hours is something which is like doable. 15 hours one can spend at home, 8-9 hours of sleep for plus 5-6 hours here and there, one can spend at home. So 15 hours is not difficult if the patient is ambulatory and otherwise good. But in case they additionally need, they can use ambulatory oxygen therapy. Another story I want to tell you is I had gone for a cruise, and I had seen a lady carrying oxygen device with her and was going on an international cruise with that oxygen. So what I'm telling you is that oxygen can give you a good quality of life. Don't think oxygen is like end. And of course, it's ultimately in terminal diseases, and they have to know that the survival is limited. However, their quality of life should not suffer, and they can even go on cruise like my what I had observed earlier. She had gone to Europe cruise for 7 days on that. So yeah. So what are the advices that one needs to give to your patients when the patient is prescribed or given on oxygen therapy? I have abbreviated as what is called as TEACH. TEACH stands for T is for titration. Now, what is this titration? I come to this a little later, because oxygen is a drug. One cannot give drug without just, take 2 liters, take 1 liter, it can't be arbitrary, it can't be random. It has to be titrated and given. Oxygen is a drug and it has to be prescribed in a particular dose. You can't just prescribe it. Very, very important. I'll come to this a little later. How to do it. Second is that the oxygen delivery device has to be explained. The patient has to be told what is this device all about, what are the parts of it, and everything needs to be told, because he's supposed to look after this device. You can't use a mobile without being explained how to use it. I mean, you may come to know easily, it's self-explanatory, but some of the patients are not that very educated. One has to explain to them. Third is A, that is adverse effects. What are the adverse effects related to the devices? Anybody, any hands up on that? Anybody? One adverse effects on that. You can write on the chat box. I guess that's difficult. But yes, adverse effect, one of the most important adverse effect is the overdose of oxygen. So they have to be given in a particular dose and told to restrict to that particular dose and not just increase it whenever they feel breathless. Breathlessness is not equal to hypoxia, is not equal to increasing the oxygen dose. They have to know that and remember that, because they land up in hospital the minute they are given higher oxygen than required, they'll develop type 2 respiratory failure. So it is important that adverse effect, especially overdose, is explained to them. Plus, they can have little bit of, kind of nasal crusting, etc., near the nasal devices. One can, alternately change to the nasal, sprongs versus even the mask, alternately, so that they don't have that nasal crusting. Another one is C for smoking cessation. They have to be explained the danger of smoking along with the device. If they have oxygen around it, it can ignite a fire and can cause a major catastrophe. Last is adherence to the device. Now, this is also another very, very important aspect. Every time you talk to these patients, just make sure that they are taking for 15 hours per day. If they have any problem in taking the oxygen for 15 hours a day, if there is, then one has to resolve these problems. And, follow-up is important with these devices so that adherence can be determined. So I said first was titration. The T for teach was titration. T in teach was titration. As I said, oxygen as a drug and excess can be detrimental. There are no trials available on titration, though based on the indirect evidence from BMJ, which was published in 2015, a guideline on oxygen, recommended that oxygen titration before prescription is a good practice. How do you do it? Half a liter first, oxygen, then increase it by half a liter every 20 minutes till a target saturation is achieved. Now, I don't know how many of you come with the, get the patients who are already on oxygen. But if they are already on oxygen, trust me, I can tell you, our physicians in India do not titrate the patient. You just give the oxygen. Nobody titrates it. It's very sad, but most chest physicians just give oxygen device without even titrating. So one can make take help from nurses or something like that, to be sent home, or even on video call or anything like that. But titrate it every half an hour, every 20 minutes, increase it by half a liter till optimal saturation is achieved. Once optimal saturation is achieved, which is about 90 to 92, one then should do ABG and check if CO2 is high. If CO2 is high, then they need to have another additional titration after 4 weeks. And then if needed, they need to be given co-prescription of BiPAP or CPAP. This is very, very important part of the whole lecture. Oxygen and NIV can be pro-prescribed and should be co-prescribed if they have hypoventilation or they have increased CO2 in addition to oxygen. I'll come to 2-3 examples which will explain this better a little later. So as far as this titration is concerned, I said oxygen is a drug and guidelines do say that it should be given. It should be done. So the titration example, I'll give you a very nice example. We had a patient of a post-infectious OB. Her FEV1 was very low, 0.33 is like hardly 330 ml, which is 19% predicted. Her ABG showed, this is PO2, that is PO2 was 54 and she had pulmonary hypertension too. Mean PAP was 35. Sleep study was normal. There was no evidence of any obstructive sleep apnea or anything. She was given RTOT. 3 months after she followed up, when she followed up with me, she complained of early morning headache. And she had almost stopped taking oxygen. She said, no, I get headache because of, oxygen. How can I take it? Now, if I did one ABG, this was a baseline ABG, okay? pH of 7.4, which is normal, PO2 of 54. I'm sure you must be knowing by now. I think lecture has been taken on that. PO2 was 54, PCO2 was 30, baseline, and bicarb was 21. So she did not have hypoventilation. Normal CO2, mind you, is about 45, 44, 45. So this was normal or less than normal, and she didn't need NIV at that time. Now, when she came to me taking 2 liters, she was told to take 2 liters. So she took 2 liters. When she came to me, she had a hypercapnia, 53. Now, anybody else could have given her NIV in addition. What I did was I simply titrated her again. When I titrated her, trust me, her CO2 came down and PO2 came up to 67 from 54. So all she needed was half a liter oxygen. Because she was taking 2 liters oxygen, she was not compliant. She had become hypercapnic and she was on the verge of prescribing almost NIV. But then when I titrated, I realized that she just needs is lowered oxygen to 0.5 liters. Some people are very, very sensitive. One needs to be careful on that. So this is the explanation regarding the titration.
Dipti,
Now,
I want to interrupt you because there is a valid point here that they are not access to blood gas everywhere. In that case, how should one titrate?
I think blood gas needs to be there. You know, you need to have, 1 second, my battery is slightly low. I just, 1 second. I'll keep talking. So as far as blood gases are concerned, titration requires blood gas for sure. Now, if you don't have a blood gas access, one needs to somehow get connected with lab which has blood gases. There is no other way apart from, whoever has referred the patient to them or whatever it is, one needs to have an access to blood gas. One cannot do the titration without that. But all said and done, one can at least do this, that they can gradually increase the oxygen dosage and see whether saturation is 92. So not to over prescribe at least CO2. So if they don't have a blood gas, at least make sure that you are increasing the oxygen slowly and not giving 2 liters at a time. At least that can be done. Yeah, at least that can be done. And then take help of a lab which does a blood gas.
So that's what I've written, that in a patient with a history of type 2 respiratory failure, you really need to be cautious about yanking the oxygen without considering the fact that you can actually yank up the carbon dioxide also. So therefore, it has to be cautiously increased. There's another question by Dheeraj who is saying, we are talking palliative care. Do we need these fancy parameters like an arterial blood gas? So just to answer before giving it to Dipti, see, Dheeraj, we are talking about blood gas here only to send home patients well titrated on the amount of oxygen you use. You will agree with me that in palliative care, a lot of patients complain of breathlessness, and the first response that most doctors as well as most caregivers have is to yank up the oxygen. So this is just to be cautious that if you have been sending this patient home and you have noted a type 2 respiratory failure, in the interest of the patient's quality of life, you should warn these caregivers to use non-pharmacological techniques to alleviate breathlessness, followed by using oxygen cautiously so that you don't worsen the situation. We are not telling you to monitor the ABG on a regular basis at home. Definitely not. It is not possible. And the idea of giving the patient palliative care is also not doing repeated ABGs because it is really painful. It is just a word of caution before you discharge the patients. What about patient having breathlessness and not willing to come to hospital? Exactly. So for these patients only, if you know there's a history of COPD, if you go through his files and see a blood gas which has shown the trend for high carbon dioxide, or if the patient is drowsy, complaining of things like headache, etc., what we call a CO2 narcosis, these patients will benefit with the oxygen which is titrated along with NIV so that the patients do not feel breathless and their blood gases are adjusted with the correct use of oxygen and NIV. I hope that answers your question. Yes, we are focusing on quality of life of these patients, and when you increase oxygen in patients who are sensitive to it, you are actually going to contribute to increased carbon dioxide, which is the reason why Dipti is saying this. Dipti, you want to add anything to that?
No, all I would like to add is that in case they are not titrated or they are not given oxygen, just 2 liters, 1-2 liter le lena. So many times, so many physicians just give 2 liters without any. So if you come to know that your palliative, your patient who's under your palliative care has not been titrated, you can request to the physicians to get it titrated, or you can at least do that with the help of oxygen, just try and check the saturation and see if it comes to only 92, and then that's it. So at least you can do that. So, that's the whole idea, not to over oxygenate in patients of COPD or any of your terminal respiratory diseases, right? Can we move ahead? Okay. Now, role of adherence. So we just had one paper published recently, and trust me, this actually opened my eyes to oxygen, and it's one of the subjects which is very close to me. The compliance in our study was 45%. All the patients were not mine; they were from all over Delhi. So 45%. Adherence to patients is suboptimal because the instruction and associated higher CO2. The instruction is not given 15 to 18 hours. That's why they just take it as and when they feel breathless. And the second part is they have a higher CO2, and then that part is not taken care for. So then when they take oxygen, they develop further type 2 respiratory failure, and they kind of, don't comply. Another study, another thing which we got to know is that none of our patients received home care services. If you go abroad, you go to Europe, etc., they have oxygen nurses. They have specifically. So you can train people to become oxygen nurses and explain to them the importance of oxygen, how to give oxygen, how much to give oxygen. They can actually go to their houses and check the saturation and report to you and stuff like that, which is a regular phenomena in all the European countries. So we need to have these oxygen nurses, and that can be done by you people only. And presence of well-organized home care program, etc., family training, social support, etc., is not there. Jaake oxygen le lo. Abhi, how to take oxygen? Nobody tells. Trust me, nobody tells. Just prescribe oxygen, LTOT. So that is another important aspect that I wanted to bring it to you, that develop oxygen nurses, or people who can, in India, we get very simple, even graduate people who are, wanting some jobs or wanting some, so they can be sent home to take care of them and check the oxygen, how much they are giving, what they are taking. Another thing I wanted to bring to your notice is the timing of LTOT after the discharge. So there are no specific guideline exactly when to give. In the United States, one study, 97 patients were given LTOT. Only 50% met the criteria of LTOT after about 3 months. After discharge for about 3 months, they needed. But after 3 months, they didn't need. Only 50% of them need. Similarly, in New Zealand also, they had similar kind of a study, but there are only these two trials, no other guidelines, nothing on that. So what do you do? So what you do is that you give short-term therapy for a patient who is discharged, and you recheck them after 90 days. Do they really need oxygen? If they don't need oxygen, no need to give unnecessary, because that can cause hypercarbia also. So it is proposed that a short-term oxygen therapy has a role. Later period of time, they may require oxygen later in their life. So when they are following up later with you, you can keep checking their saturation and find out if they need oxygen or no. But not all the patients who are discharged on oxygen will always need oxygen therapy. So it's prescribed for a short period of time because it allows a patient to be discharged. Is there any role of short burst? Give oxygen if they are feeling breathless? No, there is no role of short burst of oxygen. Overall quality of life, recovery time, nothing is helpful if you give short burst like that. No point in giving that, really, not indicated. Now, NIV. I'll bring another patient anecdote for telling you about NIV. We had a 50-year-old gentleman. He was admitted with acute exacerbation of COPD. He was having a 2D echo, and his PAP was about 76 millimeters of mercury. He was oxygen dependent. OSA was real out. Mind you, 50-year-old man, he was actually, having a family, kids were small and stuff like that. His PFT was again just 30%, FE1 was very bad. At discharge, what we did was, we had done the oxygen ABG analysis. I'm sure you can read this ABG. Red I have typed is basically lower than normal and higher than normal. So PCO2 was high, PO2 was low. Now, I gave the patient LT-OT prescription and NIV prescription both, because as a physician, if I find the patient has a high CO2, I should be giving them NIV. At the time of discharge, if they have high CO2, they should be given NIV. Now I gave them prescription, and unfortunately, the way I work for organization called as ASIC. Now, this organization sometimes, is very slow in, acting, giving things. But by the way, this is the only organization which gives. No other organization in India which gives oxygen therapies to the patient at home. We just, reimburse sometimes or something like that. Now, when I gave both the prescription, he after 6 months got only oxygen at home, and he was taking it for 15 hours. He was going for work and everything. But when I did his ABG, this was the ABG. PCO2 was high, PO2 was low. So he was doing the same as what he was at the time of discharge. When he got NIV, you see the difference it made in his ABG. He started using NIV at home, and his CO2 was 45, PO2 was 70 when he came to meet me after another 6 months. So you can imagine, it had changed his life. I thought he was like, not having much time left with him, but he survived for another 5 years. We swore by his NIV. And then slowly we actually could stop his oxygen. Then again, we had to restart his oxygen because he, over a period of time developed hypoxia. But point I'm making is NIV could actually change his life, and he became oxygen free with NIV. So what are the other diseases apart from COPD, etc.? You can have patients who are on NIV with neuromuscular disorders like poliomyelitis, most motor neuron diseases, myopathies, etc. Chest wall abnormalities like kyphoscoliosis, any ventilator control abnormality like congenital late onset hypoventilation syndrome. So these are some of the additional indication apart from COPD who can be given NIV. One has to take case by case. I'll tell you why I'm giving you these indications. So what is NIV? I don't know, all of you all know this, NIV per se, no understanding of NIV at all. It's a basic small equipment. It's as much as your CPAP. CPAP, all of you all know, continuous positive airway pressure. It's a small equipment. It's like this much, just this much. Now, this small equipment, I should have put a picture. It's like, yeah, it slipped my mind. So this small equipment, it can be used for chronic or acute type 2 respiratory failure. When we use it for acute, it is very, very good. It is phenomenal. It helps us prevent intubation. For when a patient is not an acute, one gives it for chronic. So one comes in acute type 2 respiratory failure twice. It's an indication that should be going on NIV at home. As simple as that. So if they have 2 exacerbations requiring NIV to be used at home, they should be using NIV at home also. It has 2 differential pressure. One is called as IPAP, or inspiratory positive airway pressure, and one is called as EPAP, that is called as expiratory positive airway pressure. The expiratory positive airway pressure is usually lower, and usually always lower, and inspiratory pressure is higher. It has a backup rate in case the patient is unable to breathe. So all your neuromuscular diseases, etc., one requires a backup rate, etc. But in patients of COPD, you don't need a backup rate per se. So simple BiPAP or simple NIV without a backup rate will do. But it has 2 pressures and 1 backup rate. I'll tell you what is the use of IPAP, or inspiratory positive airway pressure. As I said, it is high pressure. It provides it's like this, that one needs a negative pressure to suck in air. Now that negative pressure is compensated by outside positive pressure. So they can't suck in air because of the negative, but in addition, you kind of enhance the breath to be going inside with the positive pressure. So it's as simple as that. And because it helps the breath or the air to be sucked into the chest wall, it improves the tidal volume, it decreases the respiratory rate, it improves the ventilation, overall ventilation, because the air comes with a positive pressure and tidal volume increases. It also decreases the work of breathing. Very, very important. Many of your cardiac failure also can help with this NIV. It decreases the CO2 levels and it increases the oxygenation. So it does both the duties of CO2 and oxygen, whereas LTOT only improves the oxygen. That's how that second patient of mine did not require LTOT after a period of time. Now, what is an EPAP? EPAP is a kind of a lower pressure. So the positive airway pressure, first one, IPAP, it propels the air inside the chest wall, whereas EPAP kind of stabilizes the upper airway, and there is some lower pressure required because it will help in making the patient lose the PEEP. PEEP is positive end expiratory pressure. In COPD patients, we have what is called as PEEP. Now, if you have the EPAP, then it will stabilize the pressures in the chest and it will improve the work of breathing further because it's kind of a lower pressure that they have to take in the next breath. And the important aspect is if they have obstructive sleep apnea, it kind of keeps the upper airway also open. It should be given at about 5 to 8 centimeters of water, usually not given above 8 centimeters of water, unless the patient has a obstructive sleep apnea. Only in selected cases, it's above 8. Anything else which can be adjusted in bi-level pressure or NIV? Yes, there are 3 other things. And this also, none of your chest physicians. Two things chest physicians don't do. One is they don't titrate and they don't give an oxygen prescription properly. And second is that they don't adjust this trigger and cycle sensitivity and inspiratory time. Sometimes patient can be having discomfort because these things are not adjusted well. What is a trigger? Trigger is what makes the inspiratory pressure to be delivered by the machine. How the machine knows that inspiration has begun and it has to give the high pressure. So that is what is called as a trigger. And trigger has a sensitivity. If you give, I'll come to that a little later. I'll explain slowly because these are new terminologies for you. There's something called a cycle sensitivity. Means how does the machine know that IPAP was being given, now the EPAP has to be given. So there is a mechanism by which will convert from IPAP to EPAP. And that is what is called as a cycle sensitivity. It knows now that the flow rate is decreasing. The patient is not breathing as much as it was breathing. So now the patient has started exhaling and we can give EPAP. So that is the fundament behind the cycle sensitivity. The third one is inspiratory time or TI. For how long do you give inspiration? So for that much time, inspiratory pressures will be given. So that it helps in, again, that also helps in deciding the cycle. So both the cycle sensitivity and inspiratory time help in turning to EPAP or turning from inspiration to expiration, right? I hope I'm clear on that. Do let me know if you've got any questions. So I'll come to trigger first. The trigger sensitivity is a degree of inspiratory flow change that is needed for the pressure to turn from EPAP to IPAP because it's a continuous cycle. No? So from EPAP to IPAP, IPAP to EPAP, EPAP to IPAP, IPAP to EPAP. So that kind of a thing. So when does the machine know that now the person is breathing in and that we have to give a higher pressure? That is called as trigger sensitivity. A small change in inspiratory flow will make it high trigger sensitivity. A high sensitivity is important for a patient of neuromuscular disorders, etc. In a patient of COPD, they already have a very high sensitivity. They are anyway breathing like this. You know, they keep breathing at a very high rate. So they don't need a very high sensitivity because if you give high sensitivity to them, they will kind of have a artifact leak and they'll be having a forceful breathing and they'll kind of not, gel with the machine very easily. So you don't give high sensitivity to COPD patient. You give high sensitivity to a patient of your neuromuscular disorder. Inspiratory time. Inspiratory time is usually 0.3 to 2 seconds. higher the baseline respiratory rate, the shorter is the inspiratory time, right? Now, if they have a very high respiratory rate, you can imagine they don't have enough time to, inspiratory, expiratory. You have to give them enough time so that they can inhale, exhale. In short, in COPD patient where they have high respiratory rate, you give a lower TI or a lower inspiratory time, because in them, the pressure does not equal. I mean, just remember this much, that they have to have a lower inspiratory time because they have a very high respiratory rate. The cycle sensitivity. Now, inspiratory flow rate falls below a certain levels, and then the device turns into EPAP. So that IPAP, EPAP thing, that then it knows that now it's expiration beginning and it converts into EPAP. Now, high cycle setting is recommended when they have a COPD. High means at 75% of their inspiratory flow. They are breathing at 100% inspiratory flow rate when they are on inspiration, but it decreases to 75%. So that is what is called as high. It decreases to 75%. It turns into EPAP. That's the setting you require for your COPD patient. And low is recommended when you require a high TI, when you require an inspiratory time for a longer period of time, in like patients of neuromuscular disease. I'll revise this like this. You can take a picture of this or you can use this or whatever. In COPD patient, the trigger is medium. You can actually make out it's a medium trigger, high trigger. Sometimes it's -1, -2, etc. like that. So -1 is a very high trigger sensitivity. -2 is little lower trigger sensitivity. So it's usually in COPD -2, etc. Trigger is, every machine has a different one. You can take help from your, respiratory guy or, whoever has provided the machine to them. So talk to them. If the person has been provided by a particular, let's say Philips or this or that, you tell them simply otherwise that COPD ka setting karke de. Or you can discuss with them that the patient is uncomfortable and the setting needs to be changed. So what is the setting you have taken? So this is the setting required for COPD. So inspiratory time is just like 0.3 to 1 second. Cycle sensitivity is usually high. That is 75% of the inspiratory flow rate. It turns into expiratory very easily. So this part is little confusing. So I'm repeating again. Whereas in restrictive or neuromuscular disease, the trigger is very high. They can easily trigger. Inspiratory time is also very high. They require to inhale for a longer period of time. But cycle is low. Cycle is low means at 25% of the inspiratory flow rate compared to inspiration, they will turn into expiration. So after a long period of time, long inspiratory gap, they turn into expiration. And this is normal. Medium 0.3 to 2, and this is also medium, right? So this is something which your chest physicians don't do. That's why I'm telling you in detail. And this will help your patient to breathe better at night and have a compliance to your NIV. Now, when do you give a MAC? Compliance brings us to NIV when to give. It is given at night. And that's the beauty of this equipment. If it is given at night, they can take it for 4.5 to 5 hours. And the questions that you should ask them is that, are you able to sleep well with your device? Is there any problem while sleeping with these devices? If they have a problem, they will not comply and it will not work well. It will not improve their quality of life or arterial blood gas, as simple as that. So it is very important that you talk to them that for how long they are using and is the sleep interrupted. If the sleep is interrupted with it, then you talk to your device provider or whatever. You can use nurses or something like that and check leakage, etc. Is there any leakage? Is the mask fitting well? Is there using the mask properly or no? Is it any dryness? If there is a dryness related to NIV, then also again they can't use it well. So you talk to them. I'll come to the instruction to be given a little later. But yes, 4.5 is the duration that they are supposed to take, because and this is usually in the night because respiratory failure develops in the night, or it becomes worse in the night, and neuronal input to the chest wall, responsiveness to the oxygen decreases at night. REM sleep atonia also further worsens the ventilation. So overall, a patient of COPD has a reduction in minute ventilation by 40%, whereas you and me have a reduction in minute ventilation by 20%. So they become worse at night if they have a borderline respiratory failure, and that's where your NIV helpful. So it's usually done in the night or given in the night. Unlike, so coming to leak compensation, I was talking about leak compensation. So what happens is, there is only one tube which connects the NIV mask to your, NIV you can search and look up. I really wish I'd put one picture of NIV, but there is a mask and there is a attached tubing. This tubing is only one. So they have inhale and exhalation of the gases, or the pressure happens from that. So how do they exhale? The exhalation happens with the side port around the mask. So that is a leak. That is what is called as intentional leak. And about 24 to 36, 24 in a nasal mask and 36, this leak comes in the machine. Had I been in person, I could have explained to you exactly the machines and all, but I can't bring the NIV right now in front of you. But that they have a screen in that, and there is a leak which comes in your NIV machines. That leak is 24 or 36, up to 36 for full face and up to 24 for a nasal mask is good enough. If leak is high, and auto devices may compensate by decreasing the pressure. So if the leak is high, your pressure will not be optimum and your device will not perform well. So that's why it is important to ensure that the leak is okay, and you can read it with the help of the technicians who has sold the NIV to your patient. So what are the advices that you need to give to your patients while using NIV? One is cross-check the pressure. Has the physician given any pressure? If not, please ask the physician to give the optimal pressure. Usually, there's something called as a high pressure. If it is given high pressure, 18.8 or something like that, it will help well. It will really benefit the patient. But if the patient does not, comply with that 18 pressure, it's of no use. So the first part is the pressure, optimal pressure. But if the patient is not comfortable with the pressure that you think is optimal, you can reduce the pressure to 14, 12, at least some pressure will go. So it is important that you cross-check the pressure with the physician. And if not, at least 18 pressure. If 18 pressure patient is not very comfortable, make it to 12 or 14. And this can be done with the help of your technician who has sold the machine. Make them responsible for the machine, because they know the machines well. Nobody else knows it that well. You need to learn. I know how without a physical it's difficult. But I'm sure you play with these machines and you take the help from your technicians who have sold the machine, you can learn. It's not that difficult also. You can use the humidifier. The level is prescribed on the humidifier. The humidifier that is there attached to it has a level in it. Now the water has to be either a RO water or a boiled water or something like that. And then level has to be filled up to that, not more than that, not less than that. Duration of use needs to be told to them, about 4.5 to 5 hours. Side effects like dry mouth, bloated abdomen is known. A lot of my patients, like a Mohammedan player, all this use NIV, they have a kind of a rash or a kind of a little, wound near the nose. So it is important that you understand that their device is too tight and it is difficult for them to wear these devices, and you can give them more comfortable device if they have kind of a rash near the nose. Third is, next is care of the mask. The mask which is there, an NIV mask which is there, this mask is to be washed with soap and water. And the washing, it is not something, because these masks are something which can pick up the organisms from anywhere. we've seen during our pandemic time, we don't keep mask anywhere just like that. It has to be explained to them that on a paper, on a place, which is kind of sterilized with the help of your, sprays, those which we use for during pandemics are hand sanitizer. Even that is good enough. So that hand sanitizer. So if you use something, it has to be, that surface has to be cleaned with the sanitizer, and then keep the mask there. If it is not in use, the mask has to be cleaned properly with soap and water, dried and used again. So the mask need not be washed every day, can be washed once in a week or as frequently as they can. But a simple soap water use can be good enough. They can even use the sanitizer, but the sanitizer will, over a period of time, will damage the mask. Masks are very expensive, around 5,000 it costs, and comfortable mask can cost up to 8,000. So that's why frequent use of sanitizer over a mask is not very good. Cleaning mask with soap and water is much preferred. Educate the attendant regarding the chronicity of the disease and the progression, that this disease will progress and that you need to use it, and to become worse may require to increase the NIV over a period of time if it is on a lower dosage or lower pressure. To complete the lecture, I would like to say a few take-home messages. Oxygen is a medication. Proper prescription is essential. 15 hours or more with a flow rate adjusted based on the titration is important. Oxygen machine concentrator is a machine of choice. It costs just about 40 to 50,000, and patients should be encouraged to take the concentrator, not use the cylinder. NIV may be required in some patients of LTOT. The time duration is about 4 to 5 hours, and it requires a titration of pressure, TI, trigger sensitivity, and cycle sensitivity apart from IPAP and EPAP. Both NIV and LTOT can improve the quality of life. Thank you. Thank you so much.
So thank you, Dipti. And like we told you in the beginning, these are palliative care physicians who basically also want to understand the relevance of oxygen therapy as well as NIV in a palliative care setting. So I will do a little bit of introduction of the kind of patients I see, and therefore bring the relevance of these two important issues to people who are going to be seeing patients, say, of lung cancer, COPD, interstitial lung disease, and motor neuron disease like neuromuscular degeneration, like motor neuron, like Duchenne's muscular dystrophy, which is kind of patients that we see in a home setting. So basically, palliative care physicians do end up seeing a lot of patients who are incurable and fairly advanced in their condition and breathlessness. All of you will know, and you're very well versed, that we need to try the non-pharmacological techniques to help these patients overcome their chronic breathlessness syndrome. And that includes a battery-operated fan, that includes relaxing techniques, breathing exercises, positioning, etc. And like Dipti has been saying over and over again, we must use oxygen very, very cautiously. Patients who have an oxygen concentrator and oxygen cylinder at home tend to put the oxygen first before even doing anything else for their breathlessness. Please remember that it can have detrimental side effects, not just increase the carbon dioxide, but being a drug, it also causes nascent free oxygen radical damage to the lung. So we are actually not helping the patients always. If the saturation is between 88 and 92, that particular patient does not need oxygen, and other issues like anxiety, deconditioning, a panic attack needs to be seen first. That is point number one. Secondly, the idea of having this talk of NIV at home, very often you'll have a patient already on NIV. In that situation, you guys need to know what is a CPAP, what is a BiPAP, what is IPAP, what is EPAP, what are the settings. Sometimes patients ask you, how can we alter the settings? So these are the things we've thought you should know the basics of. But otherwise, commonly, we do use NIV very often in neuromuscular degenerative conditions like MND and Duchenne's, especially when patients start complaining of breathlessness. Then the second most important is advanced lung diseases like COPD and even congestive cardiac failure. Now, the role of NIV at home in palliative care is probably not very well defined because it is sometimes uncomfortable for the patient. Sometimes patient has denied the use of any invasive or any attachments to him. In such cases, obviously the patient's choice and autonomy will help if the patient has understood that without the NIV, he may be uncomfortable. So it is also used to keep patients comfortable and focus on the quality of life. It is not just used as a life prolonging treatment. Sometimes when patients are hospitalized with congestive cardiac failure, NIV actually delays ventilation, invasive ventilation, and actually is a step between the patient being totally uncomfortable and intubated when patients have expressed desires of not being intubated. And the other is you get to buy time to not only keep the patients comfortable, but also wait for distant relatives to come and visit the patient if that is one of the interests expressed by the patient. So I wanted to tell you that both these things can be used for comfort and quality of life and not necessarily only for prolongation of these advanced chronic incurable lung diseases. So I hope I've made myself clear. Dipti, you want to add something to it, and let's throw the floor open for questions. If there's anything that anybody would like to ask Dipti.
No, so only one point. So I've, expressed that it should be used for 4.5 to 5 hours. In patients who, if you are getting a lot of neuromuscular disease, Stephen Hawking, it's not for prolonging. It's for, he's been used to mankind so much. So it's not that, it's these devices are like, done in life. They can continue with the life. And in such patients like neuromuscular disease, it can be used for longer period of time, even during the day. And if you're using mask with the NIV, then there is only one output. If you're using with tracheostomy, you need to have NIV with 2 output, inhalation and exhalation channel, because with mask it escapes. But when you have a tracheostomy, the type of NIV is slightly different. So it is important that in patients of COPD in the night, but in patients who are not COPD, it may be they use even in the daytime. Otherwise also it can be used even in daytime if they are comfortable having. That's it.
Yeah, please share your questions because that will be helpful. Both Dipti's experience and mine, because I have a little bit of overlap with pulmonology and palliative care. Dipti, there's a question for you. Indication for BiPAP, CPAP.
So CPAP is a small device. It's like it costs about 30,000, and CPAP is usually used for obstructive sleep apnea. Obstructive sleep apnea is like not really your forte. It will not come under your this, but in case you come under this, then it's CPAP gives a pressure throughout the inspiration and expiration same. It doesn't give you differential pressure. Because it doesn't give you differential pressure, the respiratory support part is little lower than that of BiPAP or NIV. That is one. Second is that CPAP can also be used in patients who are on cardiac failure. So cardiac failure patients really benefit with CPAP if they are having a cardiac disease with a heart failure.
So the point here is that continuous positive airway pressure creates a pneumatic splint to keep the upper airway open by force, because that's the problem in sleep apnea, that is the collapsing upper airways. While BiPAP, because of its 2-level pressures, actually behaves like your diaphragm, where inspiratory is a active process and expiratory is a passive process. So it kind of takes over your respiratory muscles and behaves like one. So it's indicated where respiratory muscles are poor in action. And one of the conditions, of course, could be neuromuscular, could be prolonged COPD, where you have hyperinflated chest and where the diaphragm is at a mechanical disadvantage. Another question for you, Dipti: can LTOT be used in cyanotic heart disease with hypoxia? May not be very helpful. Acha, you answered, sorry.
Yeah, because what happens is cyanotic heart diseases are the one. There is, it's a problems in the heart wherein there is a mixing of the blood. So it's a shunt. In shunt, usually giving oxygen doesn't improve their oxygenation. So shunt patients don't really do well on oxygen therapy. But
So
I
yeah, it's true. It's a mechanical mixing of the blood. So you really won't benefit with the, and also of course depends on the condition, because these different cyanotic heart diseases probably benefit better with surgery. But intervening, yes, oxygen is a good food for the heart if you're waiting for a particular surgery or a procedure to do. But I don't think it can be a solution, like how our patients live with 18 hours, or in cases of interstitial lung disease, even longer with oxygen for about, say, 6 months, 8 months to 1 to 2 years. COPD patients can even live longer with LTOT. Any more questions? I have sent some article links of NIV in palliative care to the WhatsApp group. Second thing, very common condition that I see in my non-cancer palliative practice is motor neuron disease. And motor neuron disease patients, because of the sheer illness and where there's a loss of skeletal muscle and the diaphragm, do very well with NIV, because otherwise they're gasping for breath. They are totally not a candidate for invasive ventilation and tracheostomy and ICU. So these patients benefit from morphine for chronic breathlessness along with NIV, so that they lead a decent quality of life and not gasp for breath all the time. NIV in sarcoid,
if they have type 2 respiratory failure.
otherwise there is no, and please also remember that if you have a lot of advanced sarcoidosis like interstitial lung diseases, you could have a lot of cysts and honeycombing. And sometimes this positive pressure can be detrimental because you'll end up having a pneumothorax. So Dheeraj is asking you when to stop NIV.
It's generally a lifelong thing in patients who have reversible diseases. So suppose you have a patient of ILD. Now this patient of ILD is on, let's say, nintedanib or something, and wherein he has responded, and his type 2 failure can revert to an extent. In patients like COPD, like motor neuron disease, etc., it is usually lifelong. It doesn't get stopped. So you need to tell them there is a condition where you have an acute requirement during hospitalization. But during hospitalization, if they require and they have an acute decompensation, it stops there. So there, I think your role doesn't come in. I mean, you will be called in much later. So it is at the discretion of the intensivist that now the patient doesn't need the support and can be stopped. So per se, if they are given on home ventilation, it usually has no scope of stopping it as such.
Also, when patients have not had goals of care in place and de-escalation and withholding of invasive ventilator has not been discussed, then automatically if NIV doesn't improve the patient, the next step is when you go to invasive ventilator, which is something which is outside your purview because it will only happen in an ICU and in the ward. So that's also another way to look at when you discontinue NIV. That's why we urge pulmonologists to call us early so we can actually have these difficult dialogues with patients, put down the goals of care and be very clear that this patient does not want to go and proceed into invasive artificial ventilation. And therefore, that's another important aspect. Stopping, and that you already replied. There will be an endpoint. Yes, in palliative care setting where all the difficult dialogues have been discussed, then even putting on NIV can be an issue. So if you're happy to put the patient on morphine and the patient is comfortable, then that's what our goal is. We don't need to make the patient wear a mask and struggle. But if that has not been discussed, or if the patient expresses the desire to at least try NIV, then we should definitely know how to use an NIV. Should we use sterile water or RO water in the NIV?
RO water, I said, is good enough.
You've read. Oh, sorry. I'm not seeing your messages. It's coming late to me. Great. Any other questions or doubts or situations where you all have been stuck, or some sharing of experiences? Yes, NIV can be rented.
Yes.
And correct. And also bought, and also second-hand bought.
It costs about 3,000.
And oxygen concentrators also can be rented.
Yeah. Oxygen concentrator also can be rented. Yeah.
Anybody else wants to ask, share anything? Problems faced in the home care visits? The whole purpose of this was if you are equipped with information about the basics of NIV and oxygen, you don't have to every time rush and take help from your pulmonologist who probably is busy in an OPD, and you can deal with this patient at home or in your OPD with the knowledge that you have. So if there are no further questions, we are happy to wind up this session. Dipti, yeah, can we do VBG? Of course, you can do VBG instead of ABG. You get a rough idea of the
VBG
carbon
is a very
dioxide.
good idea.
Yeah.
VBG is a very good idea because it gives a good CO2 value.
Yes.
So yeah.
And less painful and probably easier for the patient also.
Absolutely.
So no more questions. Thank you very much, Dipti. One more, sorry. If we have an NIV facility, should we suggest it for pure palliative patient? This all depends, Gajasaraj, on the goals of care. What the patient has understood, what the patient wants, the intent of using the NIV, whether it's to prolong life or to comfort. There are many debates in palliative care circles about whether are we prolonging life by using NIV. So that it has to be individualized. If the patient is very clear that is not his aspect, then we can do completely palliative sedation or aggressive treatment of his symptoms and not use any NIV. But if the patient says, oh, my son is coming from America, or the family relatives are confused, then in your interest, at least you have NIV to do instead of not doing anything at all. So that is very, very important. Thank you, Dipti, for your time on a working day. And NIV cost.
NIV costs about 60.
Yeah. But you can get second hand and you can get rent, and there are lots of markets available. So thank you very much. Thanks, Dipti. And over to